turn it right over to Dr. Akalesh and Patel.
Great, thank you. So we have three very interesting cases today. So I guess if you're a martini drinker, you know what you're getting, but there'll be a little bit of a twist in there. So Dr. Patel will take the first case. And also, I just want to remind everyone that Dr. Patel is now in his last month of fellowship, and so will be joining our faculty in a few short weeks. And so he'll be signing out.
Can everybody mute themselves? There's somebody having an animated conversation.
I think it's Anand.
It's behind me. Sorry.
Yes. So without further ado, I'll hand it over to Anand to present the first case.
All right. Thank you. Am I sharing the right screen?
Yes.
Okay,
yeah.
Great. And if someone can, I should have the annotations anonymized. If someone can just annotate and confirm that. Okay, great. That looks anonymous. Okay. So Dr. Karen Dawolski is my clinical discussant today. So Karen, if you want to go ahead and discuss the history once this moves. There we go.
Morning, everyone. So this is a case that a recent biopsy, somewhat hot off the presses, I'll be presenting today. This is actually one of the first patients who I ever saw as an attending in clinic, which was a little bit scary at the time. But this is a 30-year-old male. He has a history of a heart transplant for non-ischemic cardiomyopathy, is presumed viral cardiomyopathy in 2017, so about 6 years prior to his presentation. His transplant course was complicated perioperatively by a candidal sternal osteomyelitis, required a repeat washout, prolonged antifungals, but otherwise his heart has actually been doing very well, no episodes of rejection, well functioning. For immune suppression, he has been maintained on tacrolimus and MMF, and then a year prior to his referral to nephrology, sirolimus was added with a reduction in tacrolimus because there was a concern of CNI nephrotoxicity. So they wanted to reduce his tacrolimus as much as possible. His creatinine at that point was around 1.5. Historically, his troughs for tacro have been in the 8 to 9 range, and since then have been in the 3 to 5 range. And then the sirolimus levels have been around 2.8 to 4.4. So next slide. So from a renal standpoint, at the time of transplant, his creatinine was around 0.8 to 1, so that was in 2017, and increased to around 1.3 to 1.5 since the year of transplant. So in 2022, when that switch was made from sirolimus, it was around 1.5. And then in late 2022, after the switch, it increased to 2, and by the time he came to me in late September, it was 3.8. In terms of other urine studies in his history, he had a UPCR of 0.9 in 2018, but that was at the time of hospitalizations for infectious complications, so a little hard to interpret. But otherwise, no urine studies have been done in the time since 2018. On exam, though, in clinic, he's well appearing, no real complaints. He has not noticed any change in his urine or really anything else. Kind of a typical 30-year-old guy. He's very active. He works full time. He also does CrossFit. He doesn't have any other comorbidities, no relevant family history. And on exam, it's unremarkable. He does not have edema. His only really remarkable finding is that he's a bit hypertensive. So for evaluation, you can see there his creatinine was 3.8. The rest of his metabolic panel, other than mild azotemia, was pretty unremarkable. Did an initial serologic evaluation, which was all essentially unremarkable. His UA did have protein and occult blood, but no RBCs, and the microscopy was completely bland. Did quantify his urine albumin, which ended up being 2 grams. Again, no prior baseline on that in recent years, and his UPCR was 3, somewhat of a prior baseline, and 2018 was 0.9. Got a renal ultrasound as well, which showed some increased echogenicity and small kidneys. And I realized I forgot to put this on the slide, but his serum albumin was normal, it was 4.3. He was mildly anemic, hemoglobin was 11.3. And I did do a hemolysis workup, which was entirely negative. So looking back at his trend and his creatinine trend, you can see that it had been sort of edging up, but generally stable over the last few years. At the time, the sirolimus, which is noted there, has spiked up to 3.8, which is where nephrology is involved. And so thought this might be a sirolimus related proteinuria type picture. So said, let's try switching off the sirolimus and follow up in a couple months back to the tacrolimus. Unfortunately, he then didn't really follow up. He missed appointments, missed labs. So we ended up about 5 to 6 months later before having follow up. But at that time, unfortunately, his creatinine had increased to 4.5. And I felt like probably whatever was happening, whether it was related to CNI or sirolimus, was probably fairly chronic, but we didn't have an extremely satisfying reason, and wanted, in discussion with him, decided to pursue a biopsy just to have a more definitive diagnosis. And at that point, I also referred him to a local nephrologist because he actually lives in Eastern Washington. And we'll have the biopsy.
Yeah. All right. So if anyone has any questions for Karen, feel free to ask. And meanwhile, I'll ask you to annotate with what you would have in your differential diagnosis.
Karen, any infection that you know about when you saw?
No infections. No, he's been very healthy.
And his blood pressure was it still quite high the second time you saw him?
It was a little better. The cardiology team and me have been increasing his carvedilol a bit. It's still running on the higher side though, like 130s, 140s, but is a little bit better controlled. So basically carvedilol was being up titrated, and then some plan for addition of amlodipine if needed.
And then no hematuria, right? Or cystocytes and peripheral smear or anything?
No schistocytes. His haptoglobin was normal, and he did not have hematuria. His microscopy was very bland.
All right. So we have a few votes in here. Differential of FSGS, TMA, infection, calcineurin inhibitor toxicity, which I think all makes sense for this history. So let's take a look at the biopsy. Here I'm showing you a low power view on the Jones stain. This is one large core that I've split into two pictures, and at low power, what we're seeing is a lot of chronic injury. And so we want to see kind of what we're seeing in the right end of the cortex, where the tubules are pink and nearly back to back, and that's only present in very small portions. So we're seeing a lot of black grayish fibrosis and a lot of blue inflammation and at this low power impression. And we can also already see a lot of these glomeruli are globally sclerosed as well. All right, so we'll look closer at the glomeruli. I'm showing just a sampling of a few of those glomeruli that were, I think, in the 40s and for our total count. And so again, we're seeing a lot of sclerosed glomeruli. We're seeing a few like these couple that are more or less normal. And then there are a couple here that are abnormal. So I'll ask you to annotate again and tell me what you see in these glomeruli. All right, so I see votes for both FSGS and TMA. And so I think what we're seeing is that there are portions of these glomeruli where the capillaries are either occluded or obliterated. And so I think on this right one, it's maybe a little bit more apparent that these loops are obliterated by predominantly matrix, this black material. So this is segmental sclerosis. And in this glomerulus, I can see that it's maybe a little bit less straightforward because some of it is matrix, but a lot of this material is this pink color, which is somewhat close to how fibrin would look, but this is all hyaline material. So we have just segmental sclerosis in these couple glomeruli. Right. So in the glomeruli, this is basically all we had. We have extensive global glomerular sclerosis, upwards of 80% of the glomeruli, and then just a couple glomeruli with FSGS. All right, so one of the main clinical concerns for this patient was calcineurin inhibitor toxicity as a cause of potential cause of this chronic injury. So we're looking at some of the arterioles in this patient. And in the arterioles, we are seeing hyalinosis, and this hyaline material is all in the media. So here's the endothelium. We see the elastic lamina here, and then here's the media with the smooth muscle cells that are each surrounded by some matrix. Okay, so all this hyaline material is within the media. Here's another example of an arteriole that's not quite as neatly sectioned, but we're again seeing this hyaline material within the media of the wall. So, so one of the challenges here is to distinguish whether this hyalinosis is related to hypertension versus calcineurin inhibitor toxicity. So I'm showing here some examples from other cases. These are not the most beautiful of examples that I pulled up, but when hyalinosis is related to hypertension or diabetes, it tends to be subendothelial. And so here we're seeing the elastic lamina that separates the intima and the media, and this hyaline material is sitting on the inside of the vessel, and then it would, as it gets more severe, might encroach into the media, but it's coming from the endothelial side. Whereas when hyalinosis is due to calcineurin inhibitor toxicity, it's attributed to an injury of these smooth muscle cells, and so it can happen anywhere across the wall of the arteriole. And so it's not always on the adventitial side of the arteriole, but when we do see hyaline on the adventitial, we can be more confident that it's not due to hypertension or diabetes, and so that's why we look for that as a more specific sign of calcineurin inhibitor toxicity. So here are a few examples of these adventitial nodules that are more specific for calcineurin inhibitor toxicity. So going back to the image from this case, we're seeing it in the media. We're not seeing distinctive calcineurin inhibitor we're not seeing distinctive adventitial nodules. So it's hard to be confident that this injury is due to the calcineurin inhibitor, but it's at least suggestive of that, since it's through the media and kind of looks like it's sparing the subendothelial end of the arteriole. And the severity is mild to moderate, so we're not getting anything that looks like it would be occluding the arteriole. All right, so so now I'm going to go on to the tubulointerstitial parenchyma. At low power, we were seeing a lot of chronic injury and a lot of inflammation. And we expect to see chronic inflammation in areas of scarring. So at low power, the inflammation was maybe not terribly concerning for an active process. But when we look at higher power, so here we're looking at interstitium between these atrophic tubules where we might expect there to be scarring. We're actually seeing in the background not that much fibrosis, which would appear black, and instead we're seeing a lot of white space for edema. So this is a sign that there's active inflammation in the interstitium. And then these inflammatory cells are predominantly mononuclear, mostly lymphocytes, but there are quite a few plasma cells as well. So here's a nice example of a plasma cell with that light pink HOF representing the Golgi right next to the nucleus. And then there's a few other examples scattered around. Here is another field of view with a similar finding. So we're in the vicinity of an atrophic tubule where we would maybe expect to see chronic inflammation, but we're again seeing a little bit of white edema in this area as well. And now we're also picking out a few eosinophils, another sign of potentially active inflammation. All right, and then in this field of view, the tubules are maybe partially atrophic, but they're not as severe chronic injury in this area. So that's giving more evidence that some of this inflammation is active. It's involving better preserved portions of the cortex. We're also seeing tubulitis. And so here's a lymphocyte that has infiltrated across the tubular basement membrane. Another lymphocyte here. And we're also seeing some acute injury in this tubule. So the epithelium is attenuated and we're seeing some reactive atypia in the epithelial cells. All right, and here's one last example of one other field of view. And so we're again seeing this active inflammation in a better preserved portion of cortex. And in this field, the atypia in these epithelial cells is more pronounced. And so we're seeing pretty significant enlargement of these nuclei, and they have this kind of glassy pinkish hue to them. Okay, so I'm going to go to the immunofluorescence now. And in immunofluorescence, we had just this one finding, which were the a single finding, but significant, that there's tubular basement membrane staining for IgG. And it's fairly widespread across many of these tubules here. Okay, so at this point, I'll ask you, what are causes of tubular basement membrane deposits in biopsies with tubular interstitial nephritis? And this is a sort of check all that apply situation. All right, so I'm seeing a few votes for most of these. This was a bit of a, I mean, not quite a trick question, but all of these are potential causes of tubular basement membrane deposits. And the drug-induced tubular interstitial nephritis, it's pretty rare, but occasionally we do see deposits there as well. So all of these are potential causes of the histologic pattern we've seen, but the one that really is most concerning with the clinical history is viral infection, and particularly BK virus. And so because of that, although we don't usually see BK, or we don't often think about BK virus in non-kidney transplant recipients, but still remains a possibility, and especially with the constellation of findings in the atypia that I showed you before, that was high on my differential after seeing the biopsy. So I got an SV40 immunohistochemical stain, and what we're looking for is dark brown, strong brown staining of the nuclei to tell us that there's infection with polyomavirus class of viruses. And so I'm showing you this low power image because I thought it was pretty helpful for me to see the importance of sampling here, because we're seeing some areas with really strong staining that I'll show you in higher power. But I want to note that there are really large areas of this biopsy that are completely negative, despite having, even though we saw inflammation pretty diffusely throughout this biopsy. And so we'll look at higher power at that area that was the most strongly positive, and we're seeing that the staining is in fact in the nuclei, and these are enlarged nuclei. And it corresponds to that same field of view where I was showing you the most atypical nuclei. Putting this all together, we have a main diagnosis of polyomavirus nephropathy, which gives us an explanation for the acute tubular injury and the chronic and active tubular interstitial nephritis we saw. This is happening on a background of really severe chronic injury, which included a little bit of FSGS that correlates with the patient's proteinuria. And we might speculate that this chronic injury is potentially due to the polyomavirus nephropathy, but we can't be confident by histology alone about what's causing the chronic injury. And then we also saw some features suggesting calcineurin inhibitor toxicity, but more on the mild to moderate side of the scale. All right, so in this comment, we cited this paper, which looked at BK virus nephropathy in recipients of non-kidney solid organ transplants. And they posed this question: are we looking hard enough, that we can discuss in a bit. So there's not very much literature about BK virus in non-kidney transplant recipients. And besides this paper, mostly isolated case reports. But in this group, they had 121 patients who received non-kidney solid organ transplants, and then were referred to nephrology for elevated creatinines. And they, as a matter of protocol in this patient population, they got serum BK virus in all of these patients. And of the 121 patients that fit these criteria, 17 of them had BK viremia, so 14%. And 5 of them had biopsies, and 4 of those 5 confirmed BK nephropathy. This wasn't necessarily a complicated diagnosis to make once we had the biopsy, but we're really interested in this case mainly so that we can discuss the less typical finding of BK virus in the heart transplant recipient compared to the kidney transplant recipients we see more often. So I will hand it back to Karen to discuss what happened next for this patient.
So we'll actually give a little shout out. I had referred him to a Wenatchee nephrologist because he lives out there, and she actually checked a BK, which came back essentially like right after he went for biopsy, and it found it to be 50,000 in the blood and about 5 billion in the urine. So very much had positive viremia. And so there's not a lot of updates on his case so far because this all happened about a month ago, but he had already been referred to transplant clinic. He's going to need clearance of the viremia prior to being able to get a kidney transplant. In discussion with cardiology, they agreed to dose reduce his mycophenolate, so that was halved. And on review of his history, actually, his MPA levels have been running pretty high for a lot of years on many occasions. So got that dose down, and then ongoing considerations, which are really in under the expertise of my transplant colleagues, will be potentially switching him to leflunomide or using IVIG. But the first order of business was to reduce his MMF, and this was really just about in the last month. So I don't really have any updates on how he's done since then, but he is undergoing planning for dialysis locally in the Wenatchee area.
All right. Thank you very much, Karen, for the clinical discussion. I think we can have a few minutes if anyone has questions, comments, discussion before we go to the next case.
Hi, Anand. How can we explain the etiology of the glomerular lesions? Can be attributed from BK?
Yeah, that's an interesting question. I don't know if I would attribute it directly to the BK virus, but I think it's when there's this extent of chronic injury, it's pretty common for us to see secondary FSGS. And so, yes, I mean, I think it's just relating as a sort of sequela of all the chronic injury to the kidney.
Thank you.
Mm-hmm.
I have a question about the clinical, kind of expected clinical course. It seems like it was pretty explosive in terms of, now needing to now prepare for dialysis. Is that kind of unexpected based on the biopsy findings and kind of the severity that was seen in the biopsy? And
do you mean the rate of change of his kidney function, or that he's...
Yeah, the rate of change, because I mean, it didn't seem like the biopsy was, I mean, it didn't look that bad, right? Like,
he had about 90% sclerosis of his glomeruli and pretty extensive chronicity. So based on the extent of sclerosis, figured this was pretty chronic and unlikely much reversibility to his kidney function at this point. So that's why at this point we think he is probably dialysis bound. He's not on it yet. So maybe if the interstitial nephritis can be down tapped a little bit, potentially it could extend some more time off dialysis, but there is such extensive chronicity that we thought this was actually, or I thought that this was more showing that there wasn't a lot of reversibility to how much his kidney function had declined.
Yes, I went back to the low power view. So like maybe here, and oh, you can't see that, sorry. So there's areas like here, and here that are preserved, and almost all of the rest of this biopsy is heavily scarred. And yeah, as Karen mentioned, we had 80s percent globally sclerosed. So not a lot of recoverability based on what we're seeing in the sample.
I think it's an interesting question, though, in terms of how long this has truly been active. And, obviously this is chronic, but what is chronic? This is probably on the order of years, but how long has the BK been there? Obviously, there's other contributors too. So I think it's a really interesting question in terms of how long he's been viremic and how long this has been affecting his kidneys to lead to this degree of scarring.
But the sclerosis could be explained by him being a cardiomyopathy, chronic RAS activation, surgery, and then being on CNI causing ischemia, and then sclerosis too.
Yeah, he definitely has plenty of other risk factors for kidney damage from all those other insults as well.
Karen, do you know, are there any studies of heart transplant patients with or without kidney disease as to whether they have BK viruria or not?
Not that I've really found. There have been some small studies just looking at rates of viruria in heart transplant patients, but generally, at least in the literature I found, on pretty short timescales. So there's one study that looked at all heart transplant patients the year after transplant to see whether or not they just had viruria detectable, and the rate was relatively high, but not necessarily correlating to GFR. But that was on a very short time scale. So not really much data out there on the rates of BK in the single heart organ transplant population. Most case reports say maybe this is more common than we think, but there's not really much surveillance data that I could find. And a lot of these times, these patients aren't biopsied, so we don't necessarily find out that they had the BK in the first place. It's attributed to CNI toxicity, which is probably the case much of the time. So,
All right. I think we'll switch over to Dr. Aklash's cases now. Thank you all for the participation and discussion.
Great. Thank you, Anand. Thank you, Karen. And again, I just want to give a shout out to Anand, who actually had the first suspicion in that biopsy and advocated for the SV40 stain, which was kind of critical there. So I think, let's see. So the next case, I think, oh yeah, there's Brendan. Okay. So this next case I'm going to present together with Brendan, and we'll start off here.
So this was a man that was a consult from the ER at Harborview. He came in with the chief complaint of lower extremity swelling. He had seen his primary care office a few times over the preceding weeks. He had a known history of a hydrocele. He had swelling in his legs, also scrotal swelling. I think they were concerned about the hydrocele aspect of it. Referred him to urology and gave him ibuprofen, and I guess he continued to get worse, and so he came into the ER. Can you back up to?
Oops, sorry.
That was really his main complaint at the time. He had a little bit of nocturia that was unchanged. His past medical history is pretty unremarkable, other than having a gunshot wound. He said it was like 10 years ago at Harborview. There's nothing in the LK archive about it, so I'm not sure about the timing of that, but he did ambulate with the walker. He was sort of half bent over. He had chronic pain. He used fentanyl on a daily basis because of that, and occasionally he'd use NSAIDs over the years. I guess, yeah, I got compression stockings from the primary care office too, and then was supposed to see urology about the hydrocele. So next slide. And again, yeah, the past medical history, it sounds like he was like critically ill. He had a colostomy at one point that, subsequently taken down. I couldn't find any data, if he had AKI at that time at all. And he was known to have this spermatocele going back on both testicles a few years, and had followed intermittently with urology. He had hepatitis C that he sort of gave a history of being treated when he was incarcerated a few years ago. There was a PSA from the preceding fall that had yet to be followed up on that was mildly elevated. And that was really his main complaint. He wasn't on any other medicines other than the ibuprofen. he had just really intermittent medical care. Most of his medical record is ER visits. Had sort of unstable mental health issues. Maybe there's sort of one incident where he had his pants off and was hanging from the mirror of a school bus, or sort of like injuries like that scattered through the records. He had sort of an unstable kind of social history, I guess I would say. He had previously used injection heroin. He injected heroin. He said at different times. One time he said 5 years ago. Another time he said it was 10. Last use had been 10 years ago. He was using fentanyl on a daily basis at the time. We saw him cocaine use in the past. He was a daily smoker. Lived in a tiny house village on North Aurora. And exam, he had basically normal vital signs. Mildly elevated blood pressure. Had no peripheral adenopathy. Cardiac exam was unremarkable. There was no rub or displaced PMI or anything. He did, he had 3+ pitting lower extremity edema. I didn't do a GU exam. He had good peripheral pulses. In relation to this sort of history of past drug use, he had detectable veins. He had nice looking skin, basically. Next slide. And then the lab values are the reason for the consult. His creatinine was 1.3. That was, maybe within his baseline. There's sort of like sketchy lab values throughout various ER visits. That wasn't completely out of line with that. His white count was 4, hemoglobin mildly anemic, platelets slightly elevated. And then he had 3+ protein on the dipstick. So the ER doc ordered a protein to creatinine ratio that was 9.4. His serum albumin was 2, his cholesterol was 300, and TSH was normal. He had a renal ultrasound that's actually, I think, a few days after this visit. Had 11 centimeter kidney on the left side, 12 on the right. Had a few, more than a few simple cysts on the right side.
Okay, thank you, Brandon. So some kind of complex medical history, some potential social risk factors as well for developing kidney disease. So please
Can I
go
ask
ahead.
that
Go ahead.
before? So he, he said that the swelling really started like a week ago. Like he could sort of pinpoint that it started pretty recently.
Yeah.
And I don't know how totally accurate that was, because like the first PCP visit was like 3 weeks prior to presentation, and his serum albumin was like 2.9 on an ER visit in November. So it may not have been 100% accurate, but he really had the sensation that this had pretty abrupt onset.
Yeah. Okay.
And Brendan, had he ever had an HIV test?
There was one from a few years ago. Yeah, and like there was the positive Hep C. I think there was a Hep B that was immune with the positive core antibody. HIV was negative like a few years ago, but it wasn't like last month or anything.
Yeah. And Brendan, was the Hep C a current infection? I know there was that history of possible treatment when he was incarcerated, but
yeah, so we didn't have the data on that. We got like the PCR after the fact.
Okay. Okay. So I guess that was also in play, like a Hep C related GN could be potentially added to the list too. So okay, so thanks for your your votes here. It looks like we've got quite a spread, but maybe a little bit of a lead for AA amyloidosis, maybe minimal change disease, membranous nephropathy kind of pulling in there as well, thinking about, this elevated PSA, maybe malignancy associated membranous nephropathy. So lots of possibilities before the biopsy. So let's take a look at what the biopsy showed. Thank you, Kate. So here's kind of a low power view of the biopsy. You can see, at least the good news is that there's some scarring perhaps, but a lot of preserved parenchyma and the bright pink over here. Here you can see a little bit of tubular atrophy, some increased interstitial fibrosis, maybe some chronic inflammation. And even at this power, you can probably see that there's some segmental scarring. So, So those individuals who selected FSGS, maybe give yourself a little pat on the back so far. But let's keep looking. So here's another view, a different section, kind of going off from that segmentally sclerosed glomerulus. You can see we have some chronic vascular disease. Here's a small artery. We have got many more glomeruli over here, all patent at this power, so that's good. We had a good sample. There was very little overall glomerular sclerosis. And again, we're seeing the trend that the majority of the parenchyma is relatively well preserved. There isn't a lot of extensive chronic injury. So let's take a look a little higher power. So again, just starting first with the tubulointerstitium, we see the tubules are mostly back to back here, maybe a little bit of attenuation, so maybe some mild injury to the tubules. But the glomeruli, we can see now that they don't look quite completely normal. There is some kind of acellular light pink material that's infiltrating these glomeruli. It seems to be mostly in the glomerulus. I don't see too much in the tubulointerstitium, at least in this particular view. But let's keep looking. Good. So here's a higher power view that shows many of these the key features here. So you can see there's a little bit of interstitial inflammation and some edema here. But in the glomerulus, we can again see this kind of light pink amorphous material that's infiltrating very irregularly. So here you have kind of a glomerular segment that looks relatively spared and normal. Mesangial regions look okay. Capillary loops are patent and kind of thin and floppy looking. We're not seeing any active inflammation or necrosis or active GN-like features here, but we are seeing this pink material. And this shows features characteristic of what you probably guessed to be amyloid, right? So you can see that there's pink material that's accumulating on both sides of this thin black line, which corresponds to the basement membrane. So this is very typical of amyloid, where it kind of permeates irregularly, can kind of penetrate and pass through basement membranes and other structures, doesn't respect normal anatomic boundaries. Okay, so we've got amyloidosis. He clearly had a risk factor. We are all familiar with our experience here in the Northwest of intravenous drug use, especially heroin, and the high prevalence of AA amyloidosis in that population. So here it looks like we've got amyloid. So amyloid typically also here is a PAS stain, is very pale pink in appearance. And so again, compare that staining intensity of these amyloid like accumulations to the intensity of staining in the PAS along the Bowman's capsule, the tubular basement membranes, and a few uninvolved capillary basement membranes in the mesangium over here, which are much darker pink in staining. You can see that clearly this amyloid material kind of pops out by being poorly staining for PAS. Okay. So looks like we have a potential diagnosis of amyloidosis. So we kind of went ahead and did the Congo. And so we see nice accumulation predominantly again in the glomeruli of this congophilic material. So this is checking all the boxes for amyloid. So let's take a look at what it looks like when we polarize it. So here we see in the same two glomeruli, nice apple green birefringence and some orange birefringence as well in some areas. So very characteristic for amyloidosis here. So that would provide an explanation for his proteinuria as well. Okay. So we went on to confirm that as well. So here are a couple of views by EM. And this amyloid material was just permeating everywhere in the glomerulus. It was kind of passing through the basement membranes as well. You can see these little stick-like fibrils that are just kind of like randomly distributed and oriented within the mass of amyloid. And this is kind of an example of how our texts give you the numbers that you see in your reports. So they take these high power images. These are almost like 180,000 times magnification. They go in and put and actually physically measure these fibrils with a calibrated ruler and they do sometimes hundreds of measurements on these images to give you an average and standard deviation. And so in this case, it was right in the sweet zone for amyloid diagnosis. Anywhere between 8 to 12 is what we think about. So this was about 9.2 nanometers in thickness, with a pretty tight standard deviation plus minus 1 nanometer. Okay, so here we go. We got the diagnosis of AA amyloidosis, right? So any questions about that?
Yeah, Brendan, you said that he used heroin 10 years ago and has been clean.
Correct. Yeah. And,
But,
sometimes people don't tell the truth, but I believe them. And like I said, his physical exam was not consistent with, the majority of cases of amyloid we see where people have just, no veins. They've been a long time, heroin users, multiple abscesses, etc. They're like really healthy looking skin, healthy veins.
And then did he have any evidence of any chronic inflammation that would cause, increased IL-6 and more SAE production by the liver? I mean, unless he's like actively using it now, or there's a focus of chronic infection and inflammation.
He supposedly had like just retained bullet fragments and stuff like that, but there weren't any. No, he didn't have any chronic wounds, and white count was on the low side of normal, whatever that's worth. They didn't do CRP or anything, but there wasn't like any apparent focus of chronic inflammation.
Yeah, it's hard to believe just with that he just decompensated now as opposed to many years ago.
Yeah.
Brandon, and then you say he uses like fentanyl daily as well. Do we know how he uses it?
Smoking.
Okay. I guess there was a question in the chat from Dr. Jefferson. He's skeptical. He's like, is this really AA amyloidosis? I mean, it's good clinical history. It looks like amyloid. It measures like amyloid. It's congophilic, right? Well, let's.
The other thing I might say, partly related to that, is, I know like people don't traditionally lead with this anymore, but I couldn't help notice on his skin exam, the melanin content was consistent with being African American, having West African ancestry. So that, I guess, after the biopsy fact brought additional things to think about in the diagnosis, I guess, the differential.
Right. Especially thinking of like collapsing and things like that going into it. But we clearly have amyloid, and that explains at least the proteinuria. But the question is, as Dr. Jefferson is saying, is it AA amyloid? So I deliberately I'm presenting this to make a point. And so we did additional studies. We too were suspecting AA amyloid based on that history and our experience in receiving these biopsies, but this was our surprise. The AA amyloid was, the immunohistochemistry was completely negative. And so maybe it's some other kind of amyloid. And so we actually also had IF at that time, and it showed kind of not an absolute, but it definitely showed a bias towards increased lambda staining in those same areas where we had amyloid accumulation, predominantly within the glomeruli. And so this is maybe like a 3+ for lambda, maybe 1+ for kappa. So definitely a skew. There wasn't a bias in the tubular droplets or the tubular casts that we could notice. And so given that the AA amyloid stain was negative, despite that very suggestive clinical history in our experience, we wondered whether this was actually a different kind of amyloid, perhaps an AL amyloid. And so we signed that out as amyloidosis, and we sent it for mass spectrometry to Kelly to evaluate, what exactly was the composition of this. We also had some other additional findings that might have been contributing to the kidney injury. So our comment said that there was a slight staining bias for lambda. It suggests an AL or a primary amyloidosis etiology. At that time, we did not have any SPEP, UPEP, or immunofixation information. And so we decided, rather than trying to guess what was in the amyloid, we decided to measure it directly.
Ram,
yeah.
Just sorry to interrupt. At this point, would there be anything that would make you think about fibrillary GN?
Yeah, good point. It was, we did not see, the typical immunoglobulin and complement accumulation within the glomeruli that we typically see with fibrillary GN. It did definitely have that kind of amorphous, smudgy accumulation within the mesangium that we have seen in many cases of fibrillary. So I think the IF characteristics weren't consistent with the fibrillary GN. But that's a very interesting comment, which you'll see based on the on the mass spec is suggestive too.
And then there are case reports of Congo red positive fibrillary
That is
GN.
correct. Yeah, we have contributed to some of these as well, a congophilic as well. In this case, it was pretty brightly congophilic. And so again, we were not suspecting that per se. But as you can see from the mass spectrometry, this was typed as a lambda light chain amyloidosis. But there was a twist where there was some DNA JB9, which was detected in one of the 3 samples. Now, the IHC that was done after for DNA JB9 was very smudgy, and so we didn't think it was a clear positive. And so overall, we don't think that there is a concurrent fibrillary GN here. And we think that this is really kind of a primary AL lambda light chain amyloidosis. But yeah, very interesting discussion on findings here from mass spec.
Wasn't on the EMs, the fibrils weren't that big, right?
Yeah, I mean, there's a little bit of, subjectivity in those, the measurements, even for our techs with that. So yeah, typically amyloid, we're going to be closer to about 10. Fibrillary is reported to be more around the 20 nanometer mark, though in our experience, it's probably closer to the 10 to 15 nanometer mark. So there's definitely overlap in the range of the diameters that we can see in both those entities. So the diameter alone was not going to rule in or rule out fibrillary GN. Great points. Okay. So Brandon, if you wanted to just give a quick update on the follow-up here.
Yeah, I really don't have any clinical follow-up. All that is basically still in motion. He ended up having an IgG lambda SPEP and was referred to Fred Hutch. Sort of the rest of the workup's still pending.
Okay, great. Yeah. So I thought this was, of course, kind of a nice example. I know we're all familiar with this study, and also work by Kelly as well, right? So we know that in our population, with any history of any heroin history use intravenous, and especially associated with active use and skin lesions and muscle lesions, that there's a high incidence of AA amyloidosis due to the continuous inflammation related to the drug use. So I think this case, I think, had that history, but there were some signs, I think, that maybe pointed against that. As Brendan was saying, his physical exam, the skin and soft tissues looked healthy and uninvolved. The veins were all intact and preserved. So the question was again here that perhaps there wasn't a continuous source of systemic inflammation, at least related to intravenous or intramuscular or subcutaneous drug use. And so even though that was a little bit of a red herring in this case, I think it was kind of a good example for us to keep a high index of suspicion and think about other causes of amyloidosis. I was wondering what our clinical colleagues thought about perhaps sending an SPEP UPEP on individuals, even though we may suspect this. Though of course the biopsy and especially the mass spec will always provide a definitive diagnosis.
So can I comment on that? So we really sent no serologies. Sometimes we'll send the serology panel to decide if we to help us decide if we need to biopsy someone or not. We're seeing them, but it was pretty clear to me that this guy deserved a kidney biopsy. And in general, I'm relatively conservative with biopsying people where the pretest probability for secondary or yeah, for secondary amyloidosis is pretty high, especially if they have advanced CKD. But this guy didn't, this guy didn't really fit that. So that, I didn't order any serologies. The time I saw him, I guess.
Yeah.
It would have been, in retrospect. I mean, I knew I needed like to have hepatitis C rechecked. In retrospect, we probably should have checked HIV because this was like an ER consult. It might have been lost. It could have easily been lost to follow up, and so it could be public health implications, I guess. But
yeah, no, I definitely learned a lot from this case. I think this was, just instructive in terms of thinking about these patients who are challenging as well from a social aspect too. So, other questions for Brendan or for me? Yes.
So I guess the DNA JB9 was prior hepatitis C related.
Yeah, we don't know what the relative contribution was of that. I don't know if Kelly is on. I know he interpreted the mass spec. I think his cell phone on. If you wanted to comment on that, but it was not negative, but it was very smudgy looking and non-localizing by the immunohistochemistry. So, but it was kind of interesting that there was a little bit of protein that was detectable within there, whether it was admixed with the conventional amyloid. Okay.
Can I make one more comment?
Yeah, of course.
I mean, the other thing that came to mind with the amyloidosis was transthyretin amyloidosis, which tends to have more cardiac involvement than kidney involvement, but can affect the kidneys. And there's a hereditary form of that that's relatively common. People with African ancestry tends to present a little bit later, more like probably 70s or 80s, I guess. But that was one thing that came to mind when it seemed like you're hedging about the possibility of AL.
Yeah, and so, but ATTR is one of the proteins that are included and reported on in the mass spec panel, and that was negative in this instance. And so it looks like the amyloid really here is the lambda light chain amyloid, which then correlates with the SPEP result as well.
Oh yeah, for sure. I just meant like.
Sure. Great. Thank you. All right, let's move on to our third and final case with a twist. And so this is a case I shared together with Bilal. And so let's start with clinical history.
All right. So I happened to take care of this 65-year-old gentleman whose only past history was significant for hypertension, and he was taking these two drugs, lisinopril and amlodipine, on a chronic basis. Otherwise, really nothing else. And as you can see, he has no bad habits. He was employed in retail furniture business and so on, but he'd been having this progressively worsening back pain, which just got out of control. And so with severe acute increase in back pain, he was finally imaged somewhere in December 2023, last year, and he was found to have an 8-centimeter right kidney mass, together with multiple lytic lesions in the skeleton, bilateral pulmonary nodules, pathologic fractures of his ribs, several of his ribs, liver mets, adrenals, you name it, he had it all over. They went ahead and confirmed that with a bone survey, again, lytic lesions and additional skull as well as cervical vertebrae as well. So he got a CT-guided kidney mass biopsy, and it came out to be a high-grade clear cell renal cell carcinoma. And he was started on Dilaudid for pain control and was seen at Fred Hutch. Click next. So he was seen next at Fred Hutch, and Scott Takoti first gave him, of course, 10 fractions of radiation to control his skeletal pain. And then about mid-January, he was started on this combination of nivolumab and cabozantinib. And as you probably all know, nivolumab is an immune checkpoint inhibitor, and cabozantinib is a tyrosine kinase inhibitor, which has inherent VEGF inhibitor properties. Next. So after that, over the next couple of months, he was admitted at least twice for short durations. Again, same thing, severe back pain, as well as fevers, and they did infectious workups. They ruled it out and just thought that it was just the tumor burden that was bringing on the fever, and they did other things to control his pain. Next. So as I mentioned, he was requiring fentanyl, gabapentin, methocarbamol, Tylenol, as well as 2 tablets of ibuprofen daily for pain control. And Dr. Tagore, being the consummate clinician that he is, he was monitoring the proteinuria and found out that right about a month after he started this therapy, patients started having proteinuria. So he stopped the cabozantinib in late February, which would be around about a month after it was started. But he continued to have significantly worsening edema, which progressed to develop anasarca. He was unable to put any footwear on. He was wheelchair bound. He started needing compression wraps on his legs. And Dr. Tagore changed his hydrochlorothiazide to Lasix for some edema control. And here I've given some labs how things progressed. So first set of labs from January 3rd are before he started any therapy. So as you can see, they are pretty normal values. By about a month into the treatment, as I wrote above, he started having about 0.5 gram of protein with beginning hypoalbuminemia. And Dr. Tagore stopped the cabozantinib at this time. But unfortunately, he continued to progress pretty relentlessly after that. As you can see, he almost reached 17 grams of proteinuria by spot checks, significant hypoalbuminemia. At that point, he was referred to us. Next. One more click. Thanks. So I saw him on 30th of April. His creatinine was pretty normal. We did a quick, or actually, he already had a quick free light chain and monoclonal workup, which was normal. I looked at his sediment and I found numerous granular casts, some hyaline casts, renal tubular epithelial cells, but there were sheets of white cells, but without any white cell casts that I could identify. I'd sent him for a renal vein duplex that came back later as normal. So I made a few changes. I stopped his amlodipine. I changed his furosemide to torsemide. I increased his lisinopril and started him on empagliflozin. But it was clear at that time that with the severity that he's presenting, I needed to know more, so I wanted to get a biopsy.
Did he have any evidence of TMA otherwise, more other than proteinuria?
Sorry, evidence of what?
Any TMA, evidence of TMA, like low hapto?
Oh, TMA. No. Here, sorry, I didn't give the CBCs because it was completely normal. And his blood pressure wasn't difficult to control. It was pretty okay. And as you saw, his creatinine was 0.5, 0.6. So at no point in time I had any suspicion for TMA, clinically at least.
Great.
But we all know that, TMAs in these kind of situations can be renal limited as well. And you don't really have to have systemic features of that.
Right. Yeah, great. So yes, people are, go ahead.
And then around that, most of the patients who have immune checkpoint inhibitor nephrotoxicity, they have other manifestations like rash, or did he have any? I mean, nivolumab has been associated with minimal change and membranous too. So
absolutely. So that is of course, I look for these things very carefully in these people when they are sent to me when they are on an immune checkpoint. First of all, he was just a month out of his therapy, and the usual, I would say the timeline or lag period is around about, I would say 3-ish months. 3 to 4 months is the typical time period after which we start seeing immune manifestation, or at least immune nephritis. And prior to that, almost exclusively, all these people develop skin rashes. They have gastrointestinal complications. They're very fatigued. They develop small joint arthralgias. Sometimes they start showing other endocrinopathies, particularly start seeing issues with, thyroid function, sometimes adrenal function. So yeah, you're right. And immune nephritis is usually preceded by a whole lot of other systemic immune-related adverse events. Just the timeline here was it was like very quick. It was like within a month, plus the fact that he didn't have any of those things that I just mentioned and you asked.
And is he, what's his ethnicity? Is he white or African?
He's white.
Great questions. Yeah. So Bilal, I think it was about 2 months before the biopsy was done, right? 2 months after initiation of nivolumab, which was, I think, in February, and then it was kind of end of April or early May that the biopsy.
Yes, you're right. So you're right. So he was started on 19th of January. And I think the biopsy was, of course, must be early May, right? Because I saw him on 4:30.
Yes, it was
after
on
that.
yeah.
Yeah. So yeah, there have been like 4 months, 4.5 months of.
Right. So
But
kind of maybe at the shorter
Scott had
time
already
in-
stopped the cabozantinib
Right.
for the worry of the VEGF inhibition.
Correct. Right. And so it's intriguing here that, you know, the kidney function was intact, even though that, you know, tubulointerstitial nephritis, maybe on the little early side for that developing, as you discussed about the, you know, 3 to 5 months range. But yeah, so that kind of makes sense that the kidney function was kind of preserved. So
very preserved, yep. And I was very surprised because the urine sediment was like packed with white cells.
yeah, right. So we have a few options here. Maybe maybe a lead for membranous nephropathy. I think I saw someone scribbling NE, maybe like a NEL1 or, you know, malignancy associated membranous nephropathy in the setting of kind of metastatic carcinoma. There are some maybe related concerns about, you know, a TMA or collapsing type GN glomerulopathy related to the VEGF inhibition, even though this was quite remote. And the kidney function dysfunction was progressive even after the medication was stopped. So let's take a look at the biopsy. So here's kind of a low power view. Thank you, Kate. Showing relatively well-preserved kidney parenchyma again. So lots of pink here. We can see some glomeruli that are patent. Maybe a little bit of chronic injury or some inflammation here, and some blood vessels as well. We see some white space within the tubular lumens. So it makes us think a little bit about some tubular injury as well. So let's start for the tubulointerstitium. So again, remember that the creatinine was well preserved, but that didn't kind of match with what we were seeing in the biopsy for the tubulointerstitium. We were seeing areas of tubular injury and simplification of the tubular epithelium. Again, for comparison, they should more look like this for the proximal tubules, pretty much filling up the lumen with very little white space visible. In addition, we were seeing some kind of chronic and active looking inflammation with some clusters of plasma cells, but also mononuclear cells that were kind of expanding some portions of the tubulointerstitium in the biopsy. Here's another view. Here you can see a glomerulus that looks pretty unremarkable, patent capillary loops. There's no TMA-like features. There's no collapsing features, no segmental sclerosis of any kind. This blood vessel here, also the arteriole looks relatively normal. We're not seeing a thrombus within its lumen. We are seeing some acute tubular injury here, some vacuolization type changes in the cytoplasm. Again, some simplification and attenuation of the proximal tubular epithelial cells over here, with the relative preservation of the overall tubular parenchyma in this particular view. So we looked at other areas. Again, this was a kind of a patchy process. Some areas were preserved, other areas were kind of had this appearance where we have kind of an active appearing mixed mononuclear cell inflammatory infiltrate associated with some edema. There was actually tubulitis. So again, if you look at this tubular profile over here, you can see some inflammatory cells that have made their way into the tubular cell layer. Same thing over here. So if I told you that this was a transplant biopsy, this would be suspicious for, you know, rejection here. You can even see some other additional evidence of tubular injury. Here's a little bit of a regenerative mitosis in the tubular epithelium over here as well. Again, saying that there is evidence of tubular injury, some attempt to repopulate lost tubular epithelial cells. This was associated with some patchy interstitial inflammation and edema, even though the creatinine was still normal, but perhaps maybe as a preview, you know, Bilal was seeing those casts in the urine sediment. So maybe this is where they were originating from. So let's take another look at the glomeruli. Again, pretty boring looking, right? So, I mean, the mesangial regions are unremarkable. There's no inflammation, no TMA, no endothelial cell swelling, no, you know, epithelial cell reaction to suggest like a collapsing type of glomerulopathy. So we didn't even see, you know, thickening and spike formation, though in very early cases of membranous, this could be quite unremarkable by light microscopy. So membranous nephropathy is still in play for this patient, especially given the kind of the acute onset and rapid onset. There may not have been enough time to cause remodeling changes in the basement membranes. Bilal, I forget, did you check a PLA2R at this point before the biopsy or around the time of the biopsy?
No, I did not.
Okay. Okay, that's fine. So, okay, so let's keep going. So here's another glomerulus. Again, the same kind of findings, really not too much to say here. So let's look at the IF. So here's what we saw. First of all, it was not membranous nephropathy, but we did see this, right? So here are now immunofluorescence images where we have to really increase the exposure, but I'm showing you both IgG and albumin. And here in the capillary loops, you can see them over here outlined. And out in the urinary space, where you might expect to see podocyte cell bodies, we're seeing kind of this little speckling or dusting for IgG. We also saw that for kappa and lambda, but we did not see it for albumin. Okay. So this, of course, now probably everyone is familiar with this kind of this finding in the context of nephrotic syndrome. In the absence of other immune deposits, this would be suggestive of the presence of anti-nephrin antibodies and a minimal change disease like symptomatology. So here's another pair of images. Again, we can see kind of this faint dusting. It's really subtle, and we have to really increase the exposure on the microscope to detect it. And again, at the same settings, we do not see the podocytes labeling when we stain for albumin. So when we saw this IF, and the fact that by light microscopy, the glomeruli looked unremarkable, I was basically saying we've ruled out minimal change disease, and we're now, so we've ruled out membranous nephropathy, and we're now considering a differential of minimal change disease, less likely FSGS. So when we went to the EM confirmed that we did not have detectable immune deposits. Instead, we had pretty diffuse effacement of the podocyte foot processes. You can see on the left here are the podocytes on the outer aspect of the capillary loop. Here's another view, again, pretty much 3 capillary loops, all of them showing diffuse effacement of podocyte foot processes, even maybe a little bit of microvillus transformation as well. So at this point, we were comfortable. We looked at all the tissue that was submitted. We did not see any FSGS. And we felt that this was a minimal change disease, which was associated with this IgG dusting over podocyte cell bodies that has been associated with anti-nephrin antibodies. And we'll discuss this a little bit more. Interestingly, as we also saw some evidence of tubulointerstitial injury, both an inflammatory process and ATN-like changes, which was kind of discordant with the normal serum creatinine. And so I called Bilal and said I was kind of surprised that there wasn't actually evidence of kidney dysfunction or AKI, and recommended that he follow up the patient's creatinine to see if it would increase. The good news for the patient, at least in terms of the kidney parenchyma, that there wasn't a lot of chronic injury, though of course this is all in a setting of widely metastatic renal cell carcinoma. So I'll turn it over again to Bilal.
Right. So I called Dr. Tikoti and we immediately discontinued his nivolumab, and he agreed to hold his cabozantinib as well for at least a couple of months, because I just did not want on top of it another anti-VEGF insult to the guy. So he's kind of, the cabozantinib is also on hold for about 2-month period. So we wanted to treat him along the lines of kind of sort of mixed in between what we do for immune nephritis / minimal change disease as well. So we just started with prednisone, roughly around 1 mg per kg body weight, with the starting at 80 and kind of trying to bring him down over a 3-month period, about 10. And of course, some prophylactic Bactrim with that. So just a follow-up, he has had couple of labs since that time. So we are beginning to see some improvement. The creatinine went up, and part of that could also be because I increased eosinopril, I started him on empagliflozin, So we may be seeing a little bit of that, but of course, with a lot of interstitial injury that we have seen, we probably was going to see some creatinine going up anyways at some point. So good to see albumin is slightly better now, serum albumin. And as I said, the protein came down from like a peak of around about 18 grams to about 6.5 grams at this point. So rituximab is at the back of my mind. So I'll see how his response continues over the next at least a month or so. Then from there, I can kind of figure out whether that's something that I need to employ if he doesn't respond well to this regimen.
Great. So so we actually also sent some of his serum to Brigham, to Dr. Wine's group, and she was able to confirm the presence of anti-nephrin antibodies in this patient. And so I thought this was a kind of an interesting case, as Abal astutely guessed at the beginning about nivolumab, or immune checkpoint inhibitor associated glomerulopathies and minimal change disease. So that is a rare but known association. I thought this was a very interesting case because we were actually able to actually demonstrate the presence of an autoantibody in the setting, rapid onset of autoantibodies in the setting of immune checkpoint inhibitor inhibition. So let's discuss that a little bit more in detail. So of course, this is now kind of a 2-year-old story now, at least, where Astrid Wine's group at Brigham had demonstrated the presence of autoantibodies targeting nephrin, which is a key component of the podocyte slit diaphragm, in a fraction of patients with minimal change disease. Her group was able to demonstrate that the levels of the antibodies were tracking with the disease activity, so that when patients were in active disease, they had detectable antibodies, versus when they were in remission or had responded to treatment, the antibodies were undetectable. They use an ELISA approach where they pre-clear with sheep red blood cells to clear out the high prevalence of anti-GalNAc antibodies that are present in most patients. So by reference, their cutoff is about 100 or so units per mil in their ELISA assay. The patient that we just described here had a low titer about 200, so comparable to this patient over here. So still clearly positive, but not a super high titer that sometimes can be seen in these patients. Now, Astrid's group would also describe this kind of dusting phenomenon, which is seen over the podocyte cell bodies. And they were able to also demonstrate that these little dust speckles correspond to nephrin that has been moved from the slit diaphragm into an intracellular vesicle or endosome within the podocyte. So there is a mislocalization or redistribution of nephrin together with the autoantibodies that are targeting it. Now, I use this as kind of as a foil to kind of discuss this recent article that just came out in New England Journal just a couple of weeks ago. This was kind of a follow-up and much more expanded study by Toby Huber's group in Germany, with a whole list of other collaborators as well, and mostly in Europe. And so they were able to then take that initial observation from Astrid's group and really expand it and try to test how widespread this might be. Now, in Astrid's original manuscript, they had about 30, 40 patients. They saw a prevalence of about 30% of patients with minimal change disease having the presence of these anti-nephrin antibodies. The confounding factor there is that not all those patients were treatment naive. And so it basically kind of handicapped their ability to test what the prevalence of these antibodies may truly be in naive, untreated disease. And so Toby Huber's group, with a much larger cohort, they were able to try to overcome some of the limitations of that first examination. So here they looked at both adult patients with a variety of nephrotic syndromes and GNs, and they also looked at pediatric patients. And so they were able to find that there's a fairly high prevalence, so maybe a little higher than was seen in Astrid's study, almost 42% of patients with minimal change disease had detectable anti-nephrin antibodies, much lower percent in FSGS, primary or otherwise, and almost undetectable in other glomerular diseases. Most interestingly, the patients who were symptomatic, had nephrotic syndrome, and had not been treated had a very high incidence, almost 70% in that case. So again, suggesting that these antibodies are present in a high proportion of the population before any treatment has initiated, and at the peak of the nephrotic symptoms as well. This prevalence was even higher in the pediatric population, especially in those patients who were nephrotic and prior to receiving treatment, almost 90% of those patients. So again, consider that this minimal change disease is the most common cause of nephrotic syndrome in patients. These patients are often not biopsied, but are empirically treated with steroids. That initial steroid treatment can potentially rapidly mask the presence of these anti-nephrin antibodies. And so if this test should come up, hopefully as a commercial assay, just like anti-PLA2R in the future, we would want to get these titers before any treatment is initiated to establish the diagnosis. Now, Toby's group did some additional work where they were able to correlate the level of the antibody levels with disease activity. This is a line that I drew. So they had a kind of a different ELISA approach than Astrid's group, where they had to enrich and immunoprecipitate the immunoglobulins from the serum to enhance the dynamic range of their ELISA. So their relative units are not comparable to the relative units in Astrid's study because they're using a different method. But again, they're saying that, when patients have nephrotic syndrome here and high albumin to creatinine ratio, they had markedly elevated levels of these anti-nephrin autoantibodies as well. Again, showing a correlation with disease activity. They then also, so Astrid study did demonstrate the use of rituximab in a patient who was somewhat resistant to conventional immunosuppression. Toby's group followed that up with additional cases. Here's one, and here's another couple of patients. And again, here, this is an individual where the red line shows the autoantibody titer, the black line showing the albumin to creatinine ratio. And you can see again that the disease activity is kind of paralleling the levels of the autoantibodies, and that immunosuppression with steroids and cyclosporin was able to knock down the antibody levels with resolution of symptoms, but then the patient relapsed each time. And it was only after after treatment with rituximab to actually cause B-cell depletion and a couple of doses in this patient where this patient was able to have some durable remission, at least out to in this observation period. So this led them to use rituximab again in these other two patients, and again, seeing rapid response with, and they were able to track that and correlate it with the levels of the anti-nephrin antibodies. Again, kind of firming up the correlation that the level of the antibody is correlated with the rituximab. So is correlated with the degree of disease activity. I just pulled up the chat here, and Bazad mentioned also that yes, Toby's group did use immunoprecipitation to kind of increase the sensitivity of the ELISA, and also to kind of get rid of some of those natural antibodies with anti-GalNAc, which have caused problems in other groups trying to reproduce these results. So Toby's group did some additional studies where they actually had an animal model. And so kind of trying to, move along the Cook's postulates continuum here. So here they took recombinant mouse nephrin, the extracellular domain, and they did a single shot immunization to Biopsy mice, which are kind of Th2 predisposed mice, which may have actually helped in this scenario. And these mice then developed that same kind of dusting-like pattern. The proteinuria was not overwhelming, but it was definitely increased in the setting of nephrin immunization. They were able to see some foot process effacement. Again, this is not the most impressive foot process effacement, but this is actually an immunogold where they were able to see these dots of mouse IgG antibodies localizing to the slit diaphragm and on the podocyte cell surface. And so they did additional studies where they actually even did mass spec and phosphoproteomics and were able to detect a phosphorylated intracellular tyrosine in nephrin that has been known to be associated with nephrin relocalization and internalization in other model systems. And so their thesis was that these autoantibodies are functional antibodies. They bind to nephrin, they induce somehow nephrin phosphorylation, which results in its internalization, mislocalization from the slit diaphragm. And this is associated with podocyte dysfunction, foot process effacement, and proteinuria. So I think there are still some things that have to be demonstrated. I think the antibodies from human patients, it would be interesting to see if they could be transferred into a mouse model to directly prove pathogenicity, as was done for like ANCA antibodies in the past. The exact mechanisms of how these autoantibodies are actually induced still remain to be kind of deciphered. The understanding of what exactly this mislocalization is doing in human tissue specimens it remains to be understood. They also demonstrated that the levels of these antibodies are pretty vanishingly small, but they are autoantigens. They are autoantibodies, but rather than membranous cases here, rather than forming immune complexes, they're actually interfering with the signaling function of the cell. And so you can maybe think of this like myasthenia gravis, where you have autoantibodies directed against the acetylcholine receptor as well. So I want to just give you a flashback to the grand rounds case that we presented almost exactly a year ago with another patient with an immune dysfunction, which was IPEX syndrome. So this is a patient who basically lacked FOXP3 due to a large deletion in that locus, which basically clipped out the promoter and the start site for the FOXP3 gene shown over here. This patient basically had no FOXP3 and as a result had no functional Tregs, since FOXP3 is a critical transcription factor required for Treg or a main subset of Treg development. So this patient developed multiple autoimmune diseases, polyendocrinopathy. Interestingly, at 12 years of age, he had developed membranous nephropathy. And then later on, when we encountered him, he actually had developed minimal change disease, again, with this kind of dusting pattern that has been associated now with anti-nephrin antibodies, which we confirmed by co-localization with nephrin as well. So why do I bring this up? I bring this up because, now these two cases are very instructive because they've shown two different ways where peripheral tolerance can be broken and where you can generate an autoantibody. In this case, we've demonstrated the presence of anti-nephrin antibodies that are targeting the podocyte and causing minimal change disease. So when we think about antibody production, we have to remember that B cells require T cell help, both in terms of co-stimulation and cytokine release, to produce autoantibodies. But then in the context of immune checkpoint inhibitor treatment and anti-tumor immunity, T cells are also very important in terms of interacting with antigen-presenting cells and cytotoxic anti-tumor T cells to provide the right help to actually boost anti-tumor immunity. And so in this context, we can think about Tregs suppressing, APCs and making them more tolerogenic. Tregs can also directly suppress effector T cell function as well, both on the CD4-TH helper cells and the cytotoxic T cells. And so in this context, we can, unify perhaps some of those observations we had. So I told you about the IPEX patient who does not have functional Tregs. And so the suppressive capability, especially for autoimmunity, is going to be relieved or is eliminated. Similarly, when we have ipilimumab or anti-CTLA-4 or other immune checkpoint inhibitors, such as the anti-PD-1, PD-L1 blockade, now again, you are not only promoting anti-tumor immunity, but you're also promoting autoimmunity as well, which is why these immune checkpoint inhibitors are relatively contraindicated in patients with known autoimmune disease. And of course, this is more complicated, right? Because we know tumor cells can also express PD-1 and other ligands as well. We know B cells themselves can also express ligands for PD-1. So there's a very complicated interaction network between Tregs and their potential targets, such as B cells, APCs, effector T cells, and even and tumor cells. So really, what I think these two cases have demonstrated is that when we think about tolerance, there are central tolerance mechanisms where T cells are educated in the thymus to say this is self and this is non-self. But when they get out into the periphery, Tregs play a very important role at multiple stages, not only of the T cell life cycle, but also B cell life cycle, to suppress autoimmune, autoreactive responses. And these two cases have shown that by deleting, and due to a genetic cause, a deficiency of Tregs, or by kind of shifting the set point of immune tolerance using immune checkpoint inhibitors, you can break peripheral tolerance and generate an autoantibody, in this case, nephrin antibodies, providing a mechanism for the observation of glomerulopathies in the setting of immune checkpoint inhibition. So I'll stop there, and I'm happy to take any questions.
A few questions for you, just because I know we're just reached the end of our time. Quick reminder to those that need to drop off. Our last session of the year is next week, and one of our favorites, the second year fellows scholarly project. So looking forward to seeing you all at South Lake Union next week. And I'll hand it back to questioners. I think Yoshio first.
That was great, Ram. So from a clinical standpoint, though, unlike, for example, PLA2R, it seemed like the levels of the anti-nephrin antibodies basically kind of were in parallel with the clinical manifestations if you're looking just at albuminuria. Do you think it's because of the mechanism of podocyte injury, which is more direct as opposed to like immune complex formations, that's why?
Yeah, that's a very astute observation. Yeah, it's been well known that sometimes the tissue manifestation of membranous and the presence of antibodies can precede the clinical detection, serologic detection, and both on kind of the front shoulder and the back shoulder of the disease course as well. So that's a great point to think about how a functional antibody may immediately impair function versus requirement of plucking off of the antigen and formation of an immune complex. Thank you for that note. Yeah. Bob.
Yeah. Oh, this is for Dr. Malik. So, because the time lag between nivolumab initiation and minimal change was only a month, and generally it's 3 months or more. Number one, was there any drug like NSAIDs, PPI, allopurinol antibiotic acting as hapten? And then the second thing is, because you were considering rituximab, I know rituximab also has direct podocyte stabilization through SMPDL3 beta, but it's primarily a B cell drug, but B cells are also T cell drugs because B cells are also antigen presenting cells. And so rituximab shifts the balance of T cells in the favor of T regulatory cells and less T effector cells. And if we're using a drug to rev up the immune system to kill cancer cells, wouldn't that be contradictory to what you're trying to do, like trying to kill the
so
cancer cells?
of course, the first question is pretty easy to answer. No, he was not on any of those drugs that you mentioned. And yes, in our study, we also found that taking PPIs was a risk factor for precipitating immune nephritis in the patients that we'd followed. So, but he was not on any of those. With regards to your second question, well, the way I look at it is, if, for example, he had 18, 19 grams of proteinuria, right? So if he does not respond, so at some point with prednisone, so we will, of course, we'll have to go to the next step of controlling his disease process. I think of it in the terms of the renal GVH, the manifestation of immune podocytopathies like membranous, secondary membranous from that we think about as protocodator FAT1 directed membranous. So in those cases, we rev up the immunosuppression again, or we give rituximab, and then that leads to a pretty good response of resolution of the immune podocytopathy that's happening in the context of GVHD. Here, of course, it's a concern that he has active cancer, and on one hand, we are trying to boost his immune system to kill the cancer, but on the other hand, we are now trying to do the oxymoron of kind of trying to slow it down to protect him. But he can't go on with 19 grams of proteinuria either. So that's why I'm hesitant to jump directly onto rituximab. And I wanted to see how he does with prednisone first for about 3-ish months and some ancillary support. And then we'll go from there. And of course, I'll have to have a buy-in from Dr. Tricodi as well, whether that's a go or not.
Yeah. Complicated immune balancing act here. Maybe one last question from Brendan.
Hey, Ram, I was just curious, like, why did it take so long to demonstrate the role of antinephrin antibodies? That's like the archetypal podocyte protein.
Yeah, great question. I think there are several things. I think, I think the detection of that dusting pattern is very, very subtle. And it's you have to really be suspicious for it and be able to, really jack up the camera settings way more than normal immune complexes. So I think that's one challenge. I think the second is that as we've seen, that detecting the antibodies in the circulation is also tricky. There are confounding factors with natural antibodies against GalNAc. The Huber group had to kind of use the trick of immunoprecipitation to kind of enrich for the IgG antibodies. And so it was non-trivial to detect them as well. And so I think those two factors kind of made it difficult. I think nephrin is a perfect example of a functional antibody, right? It's a known signaling properties in the podocyte. It's got a big extracellular domain with multiple epitopes, which these antibodies, we don't really know which epitopes they're targeting. That's still TBD. And so more work has been done in the membranous field about the potential epitopes, but I think that same thing has to be done now with these antibodies. So I think that was kind of some of the challenges in terms of thinking about an antibody-mediated process here. But there's precedent, right? ANCA antibodies, we don't see them in the tissue, but they're functional antibodies against neutrophils and endothelial injury. In the transplant setting, anti-DSA antibodies, we very rarely detect them in the tissue themselves. Nonetheless, they're fixing complement and causing problems. So I think it's caused us to think about this in a little bit different way. Now we know where to look, and so hopefully that will advance the field further.
Well, thank you, Ram. Thank you, Anand. And for all the discussion and participation. With that, we'll close. Everyone have a great weekend and look forward to seeing you all in person next week. Bye.